It's quite humbling to be here in the company of many people who I know are real experts in this and who have been, with whom I've worked on many projects before. And I'm just delighted to be here. And global health security is an idea whose time has come, and it's fantastic to see the turnout. Honored to be, humbled to be considered a bold thinker. One who really is a bold thinker, Larry Summers, a famous U.S. economist, estimated that in the next 50 years, terrorism is likely to cause the world economy trillions of dollars in setbacks, both in prevention and response to terrorism. And climate change is likely to cost us as a human society an almost equal amount of trillions of dollars over the next 50 years. But so are outbreaks and epidemics, in the same order of magnitude of cost to the global economy, just foreseeing what has happened and what's likely to happen. And whereas since 9/11, the U.S. has, I think understandably, been investing $100 billion a year in fighting terrorism, and we've pledged trillions of dollars in the fight against climate change, we don't have anything like that invested in preventing or trying to mitigate the likely effects of outbreaks and epidemics. And the infectious disease challenge to the health capacities of countries around the world has been very much in the headlines, certainly with the Ebola epidemic in West Africa, which took all of us by surprise, and Zika in the Americas. And I don't think there are probably more than a handful of people in the room who had ever heard of Zika. And of course, its name comes from Uganda, where I was ambassador, and I driven by the Zika forest, but never heard of the virus bearing its name. And we continue to have cases of Middle East respiratory syndrome and of avian influenza, which, because we are now alert to them, we're able, through surveillance, to prevent, at least in most of the instances, from becoming epidemics. But these are huge threats to humankind, and if we let down our vigilance, or if we don't have the right surveillance and response in place, these could be direct threats to the U.S. population. It's a cliche to talk about the ever more connected world, about diseases traveling quickly. Just came from U.S.-Mexico Border Health Commission, and there were a number of references to walls not being very good at keeping out pathogens. And and we've learned that we do need, in the world's response, to strengthen the weakest links. The difficulty with preparedness is that when we're successful, nobody notices. And everyone knows, however, if the global community is not prepared. And based on what we've seen the past few years, the global community is, in fact, not prepared. And we do have at our disposal, though, the tools that we would need to protect both the homeland and reducing risks around the world. And we sometimes exaggerate the threat to the general public and underestimate the threat to health workers. That was certainly true in the case of Ebola. I think if you were living in the United States in 2014, 2015, you were actually 8 times more likely to be a Republican candidate for president than to contract Ebola. And we perhaps weren't as well prepared for the presidential election as we were for Ebola, but it was only health workers who, in fact, were infected on our soil. But we hear a lot about the Ebola virus, the Zika virus. These are major health threats, but the international community is probably most at risk from influenza. And we're always working on influenza preparedness as the ever-present threat, and the strong seasonal vaccination programs ensure greater production capacity and some degree of public confidence in the vaccine when the next flu outbreak hits. But years of investment in pandemic influenza preparedness has been a strong platform for our ability to prevent, detect, and respond to emerging infectious disease threats, both at home and in our work abroad. Vaccine manufacturing diversity, for instance, has grown enormously since bird flu outbreak, and we have a pandemic influenza preparedness framework through WHO, which we hope will make vaccines or other countermeasures more readily available to countries where the flu vaccines are endemic or where from which the samples have been shared. Ebola was a little bit of a different case. It galvanized global attention and resources. We strove to eliminate active cases, help the affected countries recover. Certainly a lesson that the strength of the fundamental health system is crucial. And of course, WHO's initial response, we look to WHO to be our global platform on which we can intervene and can do some of the surveillance and reporting and norm setting for us. But it's very much dependent on having a vibrant Ministry of Health and a health system to which overseas experts can plug in. And that very much was not the case in Guinea, Sierra Leone, and Liberia. And so the threat of the Ebola virus is still present. We can't be confident that we have the right systems in place. But at the same time, we do have, I think, a lot of lessons constructively learned. And one which actually preceded the outbreak in West Africa that I'm familiar with is that until 2014, the biggest Ebola outbreak in the world had been in northern Uganda. There were a couple hundred people killed. And but systematically over the intervening decade, CDC and the Uganda Virus Research Institute, with cooperation from a number of partners, built an Ebola lab. And of course, during the outbreak in West Africa, when there was a case in Uganda, which there is almost every year, they were able to identify it within 24 hours, to isolate the patient, and in fact, there were only the initial patient died, and it did not become an epidemic. And this public health infrastructure, the sense that we know what to do, and that in a country like Uganda, which has very imperfect health system, which is many of the disadvantages that countries in West Africa have, nonetheless now has the capacity really to be a world leader in detecting and dealing with Ebola. And I just, by the way, for those of you who know Uganda, I failed at a number of things when I was ambassador there, but one of them was that the street in front of Parliament, though it's a very beautiful part of town for those who know Kampala, is named after Siad Barre, the dictator of Somalia, who doesn't deserve much honor in any capital. And I had a failed campaign to rename the street for Matthew Lukwaya, the heroic physician who died fighting Ebola in Gulu in 2000. That was not a success, but if there's any legacy any of you would like to carry on, the Matthew Lukwaya street renaming is one that I encourage. The resources that were not in place before the Ebola outbreak to help in the response included funding, but certainly weren't limited to that. But we do have the international instruments in place. The international health regulations do provide a very good outline of what countries need to do to be prepared and to respond to outbreaks. And of course, in 2014, when Ebola broke out, almost no countries in Africa had fulfilled their commitments, even though they were supposed to have been done by 2012. And we did launch, before we knew Ebola was a problem, the Global Health Security Agenda, which was a kind of springboard to action. So many countries who had done self-assessments under the international health regulations did not want external evaluation or assessment of their preparedness, but that changed within a matter of months, and there were 100 countries that asked WHO to look at their preparedness for an Ebola outbreak. And the Global Health Security Agenda, which was an initiative of the U.S. government, but certainly co-chaired by WHO and with a couple dozen initial partners, is a catalyst that can really devote not just the energy or the advocacy, but actually some money to helping countries fulfill their commitments under the IHRs and to do an objective assessment of what the deficiencies might be. Zika virus, of course, has been around since 1947, but as of this month, there are 31,000 identified Zika cases in the United States and its territories, vast majority of those in Puerto Rico. And we were, in fact, not prepared, and we are hoping that on the continental United States, the preparations will limit the spread of Zika from the spots in Florida and probably Texas where it's broken out. But the capacity building of strengthening not just health systems, but systems for health, I was last week with Secretary Burwell in Cuba, and although we don't have 100% confidence that the Cuban surveillance reports are accurate, they certainly, even if they're close, the vector control system that Cuba has in place, which were not necessarily aren't under the Ministry of Health but under other authorities, are in fact quite impressive, and they are confident that they really have been able to, as soon as there's any kind of outbreak, to be able to reduce the mosquito population in where that outbreak has occurred, and seem to have been effective in preventing a Puerto Rico-like spread of Zika in Cuba. Accelerating the international health regulations implementation is obviously critical. The countries have capacity in place that allow them to combat infectious diseases across the board, and of course that would reduce the global spread. We did, as the U.S., along with declare our support for more than 30 international partners in order to help strengthen their own systems. And the good news is that the G7 countries have more than matched that, so that there is a commitment by the G7 not only to support evaluation of the health systems, but to respond in providing some of the capacity that is needed or address the gaps that are identified in those surveys. The GHSA also is very multi-sectoral. We're bringing together human health, animal health, development, foreign affairs, and security sectors, looking to NGOs, to academics, to the private sector, and Bonnie Jenkins is here. Her work on that has really been remarkable, to really get not just a multi-sectoral approach, but one where society looks at its resources in total, not just in the health sector, and figures out who needs to be in the room when we're looking at the preparedness, and then in the case of an outbreak, how we're going to contain that outbreak. The World Health Organization reform has been a key part of this. The U.S. has also been in the lead in looking at what might be a better structure for WHO response. They've created an Office of Health Emergencies, and they have taken over what used to be a GHSA tool for evaluation as a joint external evaluation with the WHO brand. And there have been 18 countries that have already completed these JEEs, and more than 30 are scheduled over the coming year. The goal of having at least 50 assessments completed by the 70th World Health Assembly next May. And the transparency and collaboration which these joint external evaluations represent really are the cornerstone of global health security agenda. And the results are publicly available, at least all of them so far have been. The countries could ask that they not be, but the norm is that they would be published online, and that the host countries and donors will use this in a roadmap process to look at gaps and priorities, to benchmark levels of capacity, and to track progress. So not just WHO, but the Food and Agriculture Organization, the Organization for Animal Health, are implementing this program. GHSA is both an emergency response and a health system strengthening program. And there's certainly been a worry in the past that much of the money for global health development and security has come from our Defense Department or from security ideas. And so the name Global Health Security raises questions with a lot of people. And from our HHS point of view, this is the way not to securitize health, but to healthify security. Because a pathogen, whether naturally occurring as Ebola and Zika were, or from a lab accident, which unfortunately we've had some of over the past few years, or a malevolent actor, if there's a bioterrorist who wants to use anthrax or another biological agent to disrupt our society, the first response has to be in the health system. We have to know what the pathogen is. We have to have some systems in place to figure out its impact and what countermeasures or treatment protocols we have in place that would reverse that. And this is in the context of a paradigm shift, which groups like Apt Associates and many of your groups here, I think, are adjusting to, but it is quite a change in how even low-income countries are thinking not so much that they want American or first world partners to provide primary services for them, but a technical partnership. We're so often asked the question, who are your best experts on this, and can they come and build capacity in our country? And selfishly, we think HHS is well positioned for this because we have on the payroll many of the world's best experts, certainly in communicable and non-communicable diseases. On the other hand, this whole of society response means it's not just scientists or doctors who are going to be setting the stage for this. We need to integrate fields like sociology and anthropology, communications, things that are not necessarily expertise of bench scientists or the people who are hired for their technical expertise. So the sense of global health diplomacy among our partners is important. Many of us are veterans of the PEPFAR program, and one of the lessons of PEPFAR is that it's not just identifying the problem or being advocates or talking about it, but putting money behind it for U.S. leadership. And on global health security, through the Ebola supplemental in December 2014, we did appropriate $1 billion to CDC and USAID to lead this effort. And it's made a huge difference both in our ability to act, but also the credibility of the U.S. as a leader, a convener, and a force that really can make a change in how the world is prepared. So we at HHS are looking, we have now more than 600 U.S. direct hire people under Chief of Mission Authority and embassies overseas. We have about 1,200 locally employed staff. But our thinking, our culture, and our systems actually don't reflect HHS as a global actor. Our appropriations are very much for domestic priorities. We have authorities much more limited than USAID and state do in terms of working overseas. And our workforce isn't really designed for that. And one of my goals in the 3 months I have left at HHS is to try to give roots to the idea that we need a global health workforce within the U.S. government, as well as partners, many of whom are represented here, who have a long history of working abroad very effectively. So whether it's a natural occurrence, an accident, or a man-made pathogen, global health security and the infrastructure we're trying to put in place really are essential to our survival and to the economy that we're hoping to preserve. So I appreciate the opportunity to speak with you today. I welcome comments and questions, and you're going to hear from some real experts who will speak on the panel. Thanks very much. We're kind of at time. Do we have time for a question, or what's your thought?
Yeah.
Sure.
Thank you very much. It was excellent. Just a quick question. Would you therefore embrace what we're now looking at as called One Health?
Absolutely.
Which does what you say.
I should have put that phrase we use all the time, and it probably should have been in the speech.
I would love to see you use that phrase. Thank you.
There was. Yeah. But as you obviously know better than I do, there are probably 1 billion pathogens in the animal world, that there are viruses that could, in some hypothetical situation, spread to humans. And if we ignore that, so many of the outbreaks that we've had are of animal origin. So it's absolutely at the core of what we do.
Thank you.